The topic of discussion is epithelial tumors of oral cavity. So what all we will discuss under epithelial tumors of oral cavity? That is an introduction about these tumors, and then benign epithelial tumors and oral potentially malignant disorders, and then followed by malignant epithelial tumors. Going on into introduction. So under introduction we'll basically discuss about what is a tumor, that is what is neoplasia basically. So tumor in layman terms, it is basically a swelling of a tissue. What is a proper definition of neoplasia? It is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after cessation of the stimuli which evoked that change. So much is said. So what is the meaning of this? Actually here, so it is a growth basically, neoplasia, and it continues to exceed. So the growth of which exceeds, and then it is also uncoordinated, they are saying. Uncoordinated in the sense it doesn't have any limit for the growth. So it is a growth which exceeds and then it is uncoordinated in an excessive manner even after the cessation of stimuli. So anything in the body abnormal, it occurs only after a stimulus. So but if you remove the stimulus, the growth will stop. But here the neoplasia, even after you remove the stimulus, it tends to grow more and more. So that is called as a neoplasia. That is, even you stop the stimulus, it continues to grow in an excessive manner. So that is basically neoplasia or a tumor. So now going on into benign epithelial tumors. The first one is squamous papilloma. So basically squamous papilloma, as we discussed, it is benign epithelial tumor which shows an exophytic growth, that is growth towards outside, and it is pedunculated, that means it has a stalk and has numerous finger-like projections like shown in this picture, numerous finger-like projections. So it results in a verrucous or a cauliflower-like appearance. So because of those finger-like projections, it gives the appearance of cauliflower-like appearance. But what is the causative factor for the squamous papilloma? That is etiology. And before this squamous papilloma, it occurs most commonly on tongue, lips, buccal mucosa, gingiva as well as palate. And going on into etiology, it is mostly caused by human papilloma virus 6 and 11. So what does this HPV do? Human papilloma virus do? It causes focal papillary hyperplasia of mucosa, like what we see here, finger-like projections. And what do we see under histopathology, that is microscopic picture? It consists of many long, thin, finger-like projections extending above mucosa. So here we can see an epithelium and underlying connective tissue, and the epithelium is showing numerous finger-like projections like it is pointed. And these finger-like projections have some center core, right? That is a core of connective tissue which it contains. This is at a lower magnification, but if you see at a higher magnification, you can see numerous clear cells. Now a cell is pointed out, right? That is a clear cell which is altered by human papilloma virus with a central pycnotic nuclei. And these kind of clear cells are called as coelocytes. So coelocytes is a hallmark feature of squamous papilloma, and these are clear cells, that is perinuclear clear space is seen. So this is about squamous papilloma. Next benign epithelial tumor is keratoacanthoma, which is also called as self-healing carcinoma or molluscum sebaceum or verrucoma. So these are various terminologies, and it is a low-grade malignancy that arises from pilosebaceous glands. These pilosebaceous glands, usually they are present in the skin, that is epidermis and dermis. So because they are present in the skin, this keratoacanthoma is most commonly seen on face, neck and dorsum of upper extremities. If at all, if it is occurring in and around the intraoral region, it occurs most commonly on the lips, and intraorally it is not seen. And it on the lips also, they are very solitary and they are elevated and cratery form with depressed central core or plug like shown in the picture. So they are single and also has a central core. So what is the causative factor for keratoacanthoma? So it is caused by sunlight, trauma, human papillomavirus and various chemical carcinogens. So this is about keratoacanthoma. Next, moving on to oral potentially malignant disorders. So previously there are two terms, that is pre-malignant lesion and pre-malignant condition. Now that these two terminologies, they are put together into only one thing, that is oral potentially malignant disorders. This pre-malignant lesion or pre-cancerous lesion, pre-malignant condition or pre-cancerous condition, you can call it in either way. So what is a pre-malignant lesion? It is a localized morphological alteration of tissue in which cancer is more likely to occur than its normal counterpart. Name itself shows pre-malignant lesion. That means any alteration within the tissue which is going to lead to a cancer. So if you compare to the normal tissue and this altered tissue has more chances of getting cancer. That is why it is pre-malignant lesion. And these are all various conditions, various lesions which come under pre-malignant lesions, that is leukoplakia, erythroplakia, tobacco pouch, keratosis, all these. Saying about lesion, what is a pre-malignant condition? So it is a generalized state associated with significantly increased risk of cancer. So pre-malignant lesion is localized alteration of a tissue, whereas here it is generalized state which has an increased risk of cancer. So what are all various pre-malignant conditions? Lichen planus, OSMF, Plummer-Vinson syndrome, dyskeratosis congenita, lupus erythematosus, xeroderma pigmentosum, epidermolysis bullosa and tertiary syphilis. These are various pre-malignant conditions. So now we will move on to the first topic, that is leukoplakia, which is very important to know about it. Leukoplakia, it is also called as white patch in general terms, white patch. And it is the most common pre-malignant lesion of oral mucosa. And here is a picture of lateral border of the tongue showing white patch, lateral and ventral surface. So basically this terminology of leukoplakia, right, it should be limited exclusively to the clinical condition by exclusion of other lesions. So what are all the other white lesions we should exclude? That is lichen planus, cheek bite, tobacco keratosis, leukedema, white spongy nevus, all these are white lesions. So we have to make sure to exclude all those to come into a diagnosis of leukoplakia. So based on this, a definition is given for leukoplakia. So that is, it is a whitish patch or plaque that cannot be characterized clinically or pathologically as any other disease and is not associated with any physical or chemical causative agent except the use of tobacco. So this is the definition. Now we will discuss about it. So like we have discussed before, it is a white patch. So the definition starts with a whitish patch or a plaque, and it shouldn't be looking like any other clinical or pathological condition. So we have to exclude any other clinical or pathological condition, and it shouldn't be associated with any other etiological agent, that is any physical or any chemical agent except the use of tobacco. So tobacco usage is very important to call it as leukoplakia. So what are all the various forms of leukoplakia, that is clinical variants of leukoplakia? So generally they are of two types, homogeneous leukoplakia and non-homogeneous. Under homogeneous leukoplakia we have smooth, furrowed, ulcerated, and under non-homogeneous leukoplakia we have nodular speckled. So homogeneous leukoplakia, what does that mean? Homogeneous, that means a complete white patch. So they are uniformly white. So if you see this picture, there is a uniform white patch on the lateral to ventral surface of the tongue, and sometimes this uniformly white patch can be smooth, furrowed or ulcerated also. And if you see in the second picture, a white patch is seen with central red lesion. So that means part of the lesion is white and part of it is red. So it is a non-homogeneous leukoplakia. So what is this nodular speckled? It is a well demarcated raised white areas. If they are seen with a red patch, then it is nodular speckled. So what are all the various causes of leukoplakia? So etiology. So tobacco, alcohol, UV radiation, vitamin A deficiency, trauma and infections. These are all various etiological factors, but tobacco is the commonest cause for the leukoplakia. Rest all will act as synergistic factors. Next, what is the histopathology of leukoplakia? That is microscopic appearance of leukoplakia. So basically the main hallmark of leukoplakia is epithelial hyperplasia with surface hyperkeratosis. This keratosis, it can be with or without epithelial dysplasia. So you should say like histopathologically as hyperkeratosis with or without epithelial dysplasia, but not leukoplakia. So these 12 are the features of epithelial dysplasia. So to call lesion as a dysplasia, you should be able to see these features, these 12 features. So let's discuss them by seeing some pictures. So this is a picture showing bulbous rete ridges or drop shaped rete ridges. So if you basically see an epithelium and connective tissue, you will see that V shaped rete ridges, right? So when you see a leukoplakia or epithelial dysplasia, you will see this bulbous rete ridges, which is a very important feature. And then loss of stratification or irregular epithelial stratification. So normal epithelium has good definite layers, basal, spinosum, granulosum, corneum, like that. So here in dysplasia, that stratification is lost. And basal cell hyperplasia, the second point, presence of more than one layer of basal cell. So usually basal layer is single layer which is present in the lowest. Whereas here if you see there are 2 to 3 basal layers. So that means it is basal cell hyperplasia, which is a feature of epithelial dysplasia. The arrow is pointing to basal cell hyperplasia. Next, in this picture you can see 2 to 3 features together. First, pointing to cellular pleomorphism, that is different morphological form of a cell. Okay. So it doesn't resemble any other one. And second, this one, it is showing increased nuclear cytoplasmic ratio where nucleus is bigger and you cannot make out any cytoplasm there. And the next, it is pointing towards an abnormal mitotic figure wherein usually mitotic figures, they are present in the basal layer, but here this mitotic figure, it is almost above the basal layer, almost near the spinosum. And this is pointing towards nuclear hyperchromatism, wherein hyperchromatism is nothing but darkly stained nucleus. So these are various features of epithelial dysplasia. So based upon the presence of these dysplastic features, we can grade epithelial dysplasia into mild, moderate and severe. So how do we grade them, mild, moderate and severe? So by dividing the epithelium into 3 parts, that is from basal to superficial. So this is a picture wherein, so if you divide the epithelium into 3 layers from bottom to superficial, so if these dysplastic features what we have discussed before, if they are present only near the basal 1/3, then it is mild dysplasia. So if you see those red cells are there, those are all dysplastic cells, okay? They are restricted only to the basal 1/3. So that is mild dysplasia. And if you see the second picture, these dysplastic cells, that is those red cells, they are going towards, they are including the basal 1/3 as well as middle 1/3. So that is moderate dysplasia. If these cells are going beyond the middle third, that is towards the entire epithelium, then it is severe dysplasia. So it depends upon the thickness of the epithelium which they affect. So saying this is the actual histopathological picture of dysplasia. So first picture, it is without any dysplasia, only keratosis is there. The top layer, it is all fully keratin. So that is hyperkeratosis, which is again leukoplakia only. And in a second picture, there is an arrow there. So you see those dysplastic cells, that is hyperchromatic cells, they are only towards the basal 1/3. So that is mild dysplasia. So hyperchromatic, all those dysplastic features, they are restricted only to the bottom layer. And if you see the third picture, which shows moderate dysplasia, where these dysplastic features, they are from basal to middle 1/3. So those yellow line, right? It is. Whereas in severe dysplasia, all these dysplastic features are seen in the entire epithelium from bottom to top. So it is considered as severe dysplasia. So that is about leukoplakia. Now moving on to erythroplakia. This erythroplakia, it is also called as erythroplasia, which was first described by Quayart in 1911. Like we call leukoplakia as a white patch, this erythroplakia is a red patch. So a definition is given based on that, like leukoplakia. It is a bright red velvety plaque which cannot be characterized clinically or pathologically as due to any other condition. The same like leukoplakia only, that is, it is a red patch and it cannot be characterized clinically or pathologically as any other condition. So if you see this picture here, clinical picture, on the lateral border of the tongue, where you see bright red velvety patch, so velvety appearance. So this is erythroplakia. So what are all the most common causes? Actually, the commonest cause is unknown, and some synergistic factors are there like alcohol, smoking, and secondary infection. So these can cause erythroplakia. And compared to leukoplakia, erythroplakia has high malignant transformation. That is, chance of turning into malignancy or cancer is more for erythroplakia, that is in the percentage of 14 to 50%. And there is a variant of erythroplakia, that is speckled erythroplakia. That means it is a soft red lesion which has an irregular outline and with granular or fine nodular surface which is speckled with tiny white plugs. Usually erythroplakia is fully red, whereas speckled erythroplakia is it is granular or fine nodular red plug with tiny white plugs within it. So this is about erythroplakia. Now moving on to another very important topic, which is oral submucous fibrosis. It is a precancerous condition or pre-malignant condition, the second category. It is also called as atrophia idiopathica mucosa oris, which was described by Schwartz. This oral submucous fibrosis, it is a chronic progressive scarring of the oral mucosa. That means our oral mucosa is usually elastic and supple, right? So if at all, if it undergoes progressive scarring, then it is OSMF. So a definition is given, that is, it is a slowly progressing chronic fibrotic disease of the oral cavity and oral pharynx, characterized by fibroelastic change and inflammation leading to a progressive inability to open the mouth, swallow or speak. If you see the definition, so if we go into explanation of this definition, so it is basically a fibroelastic change as well as inflammation. So normal supple mucosa, it is undergoing fibrous change along with inflammation of the oral cavity and oropharynx. So because of the fibrous change, it results in inability to open the mouth, swallow or speak. Right. So if there is fibrosis, how can it move? It cannot move. So it resulting in inability to open the mouth, swallow or speak. So if you see this picture, it is a picture of soft palate and uvula. Here the whole soft palate is involved with OSMF, where blanching is seen. You cannot see that pink soft palate, right? Whereas uvula is in the normal color. So this is a feature of OSMF. What is the causative factor for this OSMF to occur? The most important factor, etiological factor, is betel quid and its components. What are its components? Arecolin, which is an alkaloid, and this alkaloid, what it does is like it stimulates the fibroblasts. What does fibroblasts do? It helps in production of collagen, but here they stimulate the fibroblasts that the collagen percentage is increased by 150%. So other than betel quid, it is capsaicin and other nutritional factors like iron and B complex, and then some immunological factors all contribute to impaired degradation and excessive production of collagen by fibroblasts. So usually there should be a balance between degradation as well as production, right? But here production is more and degradation is less. That means more and more collagen is getting deposited. So more and more collagen deposition results in fibrosis, indirectly reduced mouth opening, trismus. Okay. So that is the main pathogenesis behind OSMF. So how does it present clinically? So initially there will be pain and burning sensation. As I told you, there will be fibroelastic change and inflammation. Inflammation, the main important feature is pain and burning sensation, right? Along with pain and burning sensation, there will be vesicles as well as ulcers, and salivation will be impaired, and this fibrosis, even it involves the eustachian tube. That is why hearing loss also will be there. So these are all initially. What will happen in the advanced stages? There will be restricted mouth opening. How this restricted mouth opening happens? Because of more and more formation of the fibrous bands. If the patient keeps eating that betel quid, that is, if he keep chewing the betel quid, there will be fibrous bands which will form, and on the buccal mucosa they will be vertical in nature, and then later involvement of fascial pillars and pterygomandibular raphe, and then from there it starts to spread to pharynx and pyriform fossa. All these results in restricted mouth opening. Here is a picture where the patient is showing restricted mouth opening or trismus, where normal mouth opening is around 40 to 75 mm, but here if you see, the mouth opening will become less than 20 mm. So much will be the trismus here. Next, what is histopathology of OSMF? That is microscopic picture. In this picture you can see an epithelium and underlying connective tissue. So what will be the epithelial changes? Epithelium will become atrophied without any rete ridges. Can you see any rete ridges? No, it is a flattened epithelium or stretched out epithelium. And the underlying connective tissue will be hyalinized or densely collagenous. You can see bundles and bundles of collagen there with less number of blood vessels, that is hypovascular connective tissue, and variable number of chronic inflammatory cells. Those blue dots are there in the connective tissue. Those are nothing but lymphocytes, which are chronic inflammatory cells. So these are the main important features under the histopathology of OSMF. Next, what are the investigations you will do for a patient with OSMF? So basically there will be deficiency of vitamin B12, folate and iron. So you'll ask for the investigation for levels of vitamin B12, folate and iron. And there will be increased ESR rate and anemia and eosinophilia, and increased gamma globulin components will be there, and increase in total iron binding capacity, and the percentage saturation of transferrin also will be decreased. These are the various investigations what you will see and do in OSMF, and this is in general about benign epithelial tumors as well as oral potentially malignant disorders. So here leukoplakia and OSMF, they are very important as both short note as well as long note, and oral potentially malignant disorders as such, it is important as a long note.